Good day, and a very warm welcome to the start of the Korea Foundation Virtual Dialogue. My name is Jerome Kim, and I am the Director General of the International Vaccine Institute located in Seoul, Republic of Korea. First, I'd like to introduce our speakers, joining us from Seoul and Sweden. First, Dr. Gun Lee, President of the Korea Foundation. Dr. Youngmi Ji, member of the World Health Organization's International Health Regulations Emergency Committee on COVID-19 Outbreak and Special Representative for Health Diplomacy at the Korea Foundation. And finally, Professor Charlotte Stern, Vice President of the Ratio Institute and a professor at Stockholm University. I would like to start first by noting how many changes COVID-19 has brought to our lives. It seems like an age ago, December of 2019, when we really didn't know what was about to strike, and we celebrated the new year really unaware of the changes that COVID-19 would bring to our lives. But we've seen this virus move from country to country, affecting millions of people, killing hundreds of thousands of people, and putting billions of people in lockdown, causing dramatic social and economic consequences for countries all over the world. So how did COVID-19 spread throughout the world? From the site of the outbreak in Wuhan in China, and what strategies and controls could be used to optimize the response to this pandemic? This dialogue will focus on the response of Sweden and South Korea, what we can learn from the responses, and how the international community can cooperate as we move forward. First up today, I will go through vaccine development for COVID-19. Vaccines are seen as the bridge back to normality for mankind. Then experts from Korea and Sweden will introduce how their countries have used technology to fight against the virus, and afterwards we'll move into discussion. Before we start, I would like to invite Dr. Gun Lee to deliver some opening remarks to welcome you to the Korea Foundation Virtual Dialogue. Dr. Lee?
Thank you. Dear colleagues and friends all over the world, as President of the Korea Foundation, it is indeed my great pleasure and honor to welcome you all to this Korea Foundation Virtual Dialogue. Distinguished speakers with us today, Dr. Jerome Kim, Director General of the International Vaccine Institute, Dr. Youngmi Ji, KF Special Representative for Health Diplomacy, and Professor Charlotte Stern, Deputy CEO of the Ratio Institute, joining from Sweden. Thank you for being here with us to enrich our discussions and to share your insights and vision. The Korea Foundation launched the KF Virtual Dialogue series under the theme of COVID-19 Challenges and Opportunities in collaboration with world-leading partner organizations. 5 dialogues have been held so far, bringing together experts from a variety of fields as well as government officials. The topics covered throughout the series include active use of advanced ICT technologies in Korea, the political and economic implications of the pandemic on a global level, potential challenges to democracy caused by COVID-19, and public-private partnership responses. Our journey has not only helped us understand the way the pandemic proliferated and what strategies have been taken to flatten the curve. It has also shown us what we can learn from our experiences and how to turn profound challenges into opportunities. Today's dialogue is the 6th and final in the series. The topic is COVID-19 across the globe, the cases of South Korea and Sweden. It has been designed to wrap up what we have discussed throughout the series through an overview of the COVID-19 pandemic, in addition to offering insights learned from the cases of Korea and Sweden. The vaccine issue and the roadmap for future cooperation will be also explored. Today's roster of speakers is particularly interesting. We are pleased to have with us Dr. Ji, a healthcare expert from Korea, and Dr. Stern, a sociologist from Sweden, and we are also very lucky to have Dr. Jerome Kim, a distinguished vaccine researcher, as speaker and moderator. Distinguished guests, dear colleagues and friends, as we have witnessed, the outbreak of COVID-19 has changed all aspects of our lives. Much is still unknown about the virus and therefore about our future. It is said that the changes brought by the pandemic may be permanent and that we must adjust to this new environment and new normal. While we have seen plenty of emphasis on what the pandemic has changed, I would like to mention something that will stay the same, which is cooperation. The crisis is an opportunity for cooperation, proof of the interdependency of mankind. In the wake of the virus, we will need to develop new kinds of cooperation in many different spheres. On behalf of the Korea Foundation, I would like to once again express my sincere gratitude to our speakers and to the audience present today. I hope today's webinar will not end our discussions, but instead serve as a good stepping stone for building collaborative strategies for COVID-19. Thank you very much.
Thank you, Dr. Lee. And so I will give the first of the talks on vaccine development for COVID-19. Oops. I'd like to thank the organizers of this virtual forum for the opportunity to speak today about a very important subject, something that we've been talking about, that even people who don't believe in vaccines have been hoping that we develop as quickly as possible. And that is the path for vaccine development against the SARS-CoV-2 or the COVID-19 virus. Let's start with what we don't know. And I call these known unknowns, but these are questions that many vaccine developers will ask when they're confronted with a new pathogen. The first and possibly one of the most important questions is, does infection provide immunity? And we've heard a lot of people talking about that. The belief that if a person acquires COVID-19 infection, that he or she will be immune to further infection. And we've actually known about this kind of phenomenon for a very long time. In 431 BC, during the plague of Athens, the Greek historian Thucydides reported that people who had been afflicted with the plague and who had survived were immune to further infection. And this is really a kind of classic vaccine and disease model. And just take an example, hepatitis A or polio, but you could use measles or German measles. In these cases, a person acquires the disease, and the disease may be manifest in many different ways. For instance, with polio, it could be mild or asymptomatic, or it could involve paralysis and death. So there's often a very wide display of medical outcomes in response to infection. But the bottom line is that almost all people recover completely. What does this mean? It means that the body's defensive or immune response is capable of initially controlling the infection and then eliminating the infection, and that disease-induced immune or protective response is then capable of protecting the person against future infections. That's very important because when we develop a vaccine, what we're trying to do is to mimic the natural immune response. And so the fact that a virus, that the human body can develop those responses naturally really is a good sign for our ability to potentially develop a vaccine against the virus. It's different, for instance, for the HIV virus. It's a virus that I've been working on a vaccine for almost my entire career. With HIV, we know that the human body cannot eliminate the virus. We also know that HIV can infect an HIV-infected person. So we get what we call superinfection. It's not surprising then that it's very difficult to develop a vaccine against HIV. On the other hand, since we believe that there is increasing evidence that a person who has acquired COVID-19 infection and survived may be immune to future infection, that may be a good sign that we should be able to develop a vaccine. What we don't know is how long this immunity will last, and that's a question that we will know more about as we live longer with this virus infection. The second is related to the first, and that is, which immune or protective responses are important? Is it the proteins that your body makes to inactivate the virus? These proteins are called antibodies. Or is it the killer T cells, the cells that your body makes that fight against virally infected cells? Sometimes, and often for vaccines, it's a combination of the two. But it's very important to identify these because in the end, those are the very responses that we want the vaccine to induce. A third question is, what is an appropriate animal model? So in order to accelerate vaccine development against COVID-19, we need to know whether we can use a vaccine in an animal and whether that vaccinated animal will be protected against infection. If we do that, first in a mouse, then maybe in a hamster or a ferret, and ultimately in a monkey, if we can protect a monkey against infection with a COVID-19 vaccine, then there is a better chance that that vaccine will be effective in humans. And the final question that vaccine developers always ask themselves is, are there any safety issues? Why? Because vaccines are given to healthy people to keep them healthy. And so we have a very high standard for vaccines, a higher standard even than for most medicines, because we need to protect the health of people who are already healthy. How long will it take? We get asked this question all the time, probably more often for COVID than for other diseases. But under normal circumstances, it takes 5 to 10 years to develop a vaccine. It costs between $500 million to $1.5 billion, and the failure rate is over 90%. The failure rate being if you start in the laboratory with a number of different vaccine constructs and you finally end up with a vaccine that is approved in Korea by the Ministry of Food and Drug Safety, 9 out of 10 of those vaccines will fail somewhere along the way. So very high cost, very high failure rate. With that in mind then, how do you actually develop a vaccine? You first start in the laboratory, you create a vaccine at your lab bench. Then you test it in animals. That's the preclinical stage. And then we enter the phase of testing in humans. The first part of that is called phase 1. And phase 1 studies are typically less than 50 people and are really designed to look at safety. Is this vaccine safe? If the vaccine is safe, then we often move into something called phase 2. Phase 2 is really designed to look at the vaccine in what we call the target population. So for the case of a COVID vaccine, it would be, adults, the elderly, children. We really want to see in the target population whether the vaccine induces the correct protective or immune responses. And then if that happens, we can move on into phase 3. And the phase 3 trial is really designed to answer the question, does the vaccine work and is it safe? And phase 3 trials can involve tens of thousands of people. I once was involved in a study for an HIV vaccine that involved 16,402 individuals. These are very large, very complex, and very expensive trials. If the vaccine is shown to be safe and effective, then it moves on to regulatory approval. And 100,000 pieces of paper are submitted to the regulatory agencies, the Food and Drug Administration in the United States, the Ministry of Food and Drug Safety in Korea. And they have to evaluate and basically agree that the vaccine protects and is safe. And then we can move, if they give their approval, onto licensure and sales of the vaccine. Now, that normally takes 5 to 10 years. But what we have in the COVID pandemic is 6 to 18 months. So the big question that we have is, can we take something that normally takes 5 to 10 years and compress it so that as quickly as possible we can get to the phase 3 question? Does the vaccine work and is it safe? And then move it along quickly. Can we manufacture it? And can we distribute it around the world? And that is the big question. The World Health Organization has drafted a target product profile. This is the kind of a wish list. This is what we would like a vaccine to do. And the most important part is circled in red. Those are the criteria for the measure of efficacy. How well does the vaccine work? So we would be willing to accept a minimal efficacy of 50%. So 50% protection against disease or infection. We haven't decided which. Optimally, the vaccine should protect 70%. Whether we'll achieve either of these metrics, I think, is something that we will learn as the world learns the results of the phase 3 trials that should start sometime in the late or early fall or winter. For COVID-19, though, because of the pressing urgency of this pandemic, there are now over 150 possible candidates, which is a huge number. 8 candidates are currently in human clinical testing. And the candidates fall into different types. We have what we call nucleic acid vaccines, which are composed of RNA or DNA. Some companies or organizations, academic institutions, are pursuing protein-based vaccines, similar to a large number of different licensed vaccines. Some are pursuing what we call vectored vaccines. These are taking a piece of the COVID-19 genetic material and inserting it into a different virus that will then induce an immune response against COVID-19. And some of those vectored vaccines are the ones that are farthest along. Probably the easier vaccine concept is to just grow the virus up in cells and then to inactivate it or kill it using heat or formalin. There are many vaccines, including the polio vaccines, which are inactivated and which are very effective and can be made in large quantity and relatively inexpensively. What you see in the bottom panel is the vaccine candidates by type. And what you see on the right panel, again, is a more recent update of the different kinds of vaccines that have entered human clinical trials or are in testing in animals. This actually focuses on just the vaccines that are in human clinical trials. And I think the question that everyone has is answered on this slide. Where you see the blue hatched sections, that is when the company expects to have that vaccine ready for use. So Moderna, for instance, is thinking that it will have vaccine ready for deployment in October of 2020 to January of 2021. Pfizer, by October. AstraZeneca, which is a large company, expects to have it ready by September. Johnson & Johnson, or Janssen, which is Johnson & Johnson's vaccine arm, sometime after the beginning of the year. So you can see that the companies are already planning for potential manufacture of these vaccines. What you see in the rest of the slide is where they actually are. When was the first volunteer given a vaccine? When are the first clinical data going to be available? So COVID-19 vaccine development, hopefully, is our way back to the future. What you see on the left are the Spanish steps now today, after COVID. What you see on the right are the Spanish steps in Rome before the COVID-19 pandemic. Conceptually, vaccine development is simple. We have to prove the vaccine works, we have to make the vaccine, and we have to use the vaccine. The complication comes later. We have to prove the vaccine works, but we also have to ensure that it is safe over both the short and the long term. We can make the vaccine, but we have to make it in sufficient quantity, with high quality, and at a cost that is affordable for people around the world. And finally, using the vaccine is one thing, to reduce the burden of COVID-19, but we also have to respect the need for COVID-19 vaccines around the world. And that would include low and middle income countries, which don't necessarily have the ability to pay a significant amount for additional doses of vaccine. So thoughts on the future, and it's always dangerous to look into the future whenever we talk about vaccines or vaccine development. Can we prove that a vaccine works and is safe? I think we will be able to show that there is a vaccine that works and is safe. The bigger question is, can we do that in 12 to 18 months? And we can do that only if everything works as planned. If there are any setbacks, it will take longer, and it could take much longer. The second question, can we make a vaccine in sufficient quantity with high quality and at an affordable cost? And the answer to that, unfortunately, is only maybe. The Coalition for Epidemic Preparedness Innovations, with funding from the Gates Foundation, has identified global manufacturing for vaccines in the range of 10 billion doses. The question is, can we have all that manufacturing capacity ready and producing vaccine as quickly as possible? Can we do it by next year? And I think, again, the answer is maybe. The final thing is, can we use the vaccine with respect for access and equity? And again, not a great answer, but hopefully. The Coalition for Epidemic Preparedness Innovations has global access agreements and other downstream partners who are working to ensure that access and equity exist in the allocation of vaccine resources. Will they succeed? I think that is a huge question, because if we're going to reduce the burden of COVID-19 and the pandemic, we are going to have to make sure that that vaccine gets out to 7 billion people around the world. One final caveat, and this is from E.R. Fiedler. He who lives by the crystal ball soon learns to eat ground glass. I hope that these predictions will prove to be ultimately correct, and that we will be able to prove that a vaccine works, make it, and use it with access and equity. Thanks. I think I would like to introduce the next speaker, and that is Dr. Youngmi Ji, who actually is a former board member of the International Vaccine Institute, a representative to the Strategic Advisory Group of Experts in Immunization for the World Health Organization, and currently serves on the International Health Regulations Emergency Committee for COVID-19. And she's also the Special Representative for Health Diplomacy. So, Dr. Ji, please.
Thank you very much for the introduction. It is my great pleasure to join this important webinar to share the COVID-19 response in Sweden and Korea. So I'm going to briefly summarize Korea's public health responses to COVID-19 outbreak. So I want to start with this slide showing the timeline of early stage of the public health responses in Korea. So right after the report from China to WHO about the unknown pneumonia in Wuhan, Korea CDC actually activated Emergency Operations Center on January 3rd. And then January 6th, Korea CDC also allotted the clinicians to look out for patients with respiratory symptoms with a history of visit to Wuhan. And also the drug utilization review system will support this investigation through providing travel history of patients at healthcare facilities. And then January 4 and 8, they also developed and also distributed guidance for the national designated isolation hospitals for clinicians. And then the 17th also distributed guidance for testing and management of COVID-19 and also guidance for the local government. On January 20th, government scaled up the alert level from level 1 to level 2 out of 4 level national crisis management system. And then I didn't mention here, but on January 27th, there was a meeting of pharmaceutical companies to discuss the early emergency use licensing to produce the diagnostic kit for COVID-19. So what I want to say here is actually all these actions were taken before WHO actually declared the public health emergency of international concern on January 30th. So what would be the key factors of COVID-19 outbreak responses in Korea? So I want to say there was no lockdown and only minimum restrictions. And there was social distancing based on the voluntary basis from an early stage of the outbreak. And to do this, actually, early action for testing was very, very critical. As I mentioned, emergency use licensing was done in late January, and there was a preparation of massive testing at the national level involving private sectors from early February. And of course, for us, previous experience of MERS outbreak in 2015 was the key in terms of governance, testing, and tracing. And the other important factor is very easy access to medical services for everyone. So everyone is covered by national health insurance, and we have a nationwide network of public health centers which played important role in this outbreak response. And also private hospitals, which represent about 96%, also operate within national health insurance. And we do have high number of hospital beds for per 1,000 people. So it number is 12.27 for Korea. And also the testing for COVID-19, also for the treatment, was free, and for both Korean and foreign nationals. And it was also important to recognize whole of government and society approach, including public and private partnership, and public participation and community engagement was also a critical part. So unlike MERS outbreak situation in 2015, this time I think was very transparent risk communication from government with the public and media, leading to full community engagement. And of course, we also use very innovative technologies like drive-through, walk-through, and smart tracking system for the epidemiological investigation using ICT. So this slide shows the safety protection mobile app for the people in quarantine. So everyone who will start the quarantine for 14 days will have to upload this mobile app, and they will have to report their health status twice a day to government offices. And also, the COVID-19 smart management system was developed by the Ministry of Land and Infrastructure and Transport and Science and ICT and Korea CDC. It was operated from March 26 in collaboration with Korean National Police Agency, Credit Finance Association, and 3 mobile carriers and also credit card issuers. So they all joined to create this new tracking system. So with this system, the time for the epidemiological investigation of cases was reduced from around 24 hours to only 10 minutes. So all the data was automatically accessible, and also the management of data was much secure because only limited people will have access to this data. And also government introduced spatial entry procedures. So these procedures were at the beginning to just limited countries, but starting from March 19th was expanded to all incoming travelers for both Korean and foreign nationals. And government also began testing for all travelers coming from Europe and US. And even if the testing results are negative, all travelers must go into 14 days of quarantine. And also social distancing is an important factor, and the social distancing was graded based on risk assessment criteria, so such as less than 50 new cases per day, unknown sources of infection less than 5%. So those criteria will be used for the grading of social distancing, such as daily life physical distancing, or social distancing, or enhanced social distancing. Also, our government introduced electronic barcode QR code system for entering entertainment places starting from June 10th. And because of some increase of cases in Seoul metropolitan area, and also the increase of proportion of the cases with unknown source, the social distancing in Seoul and metropolitan area has been extended beyond June 14th. And all this graded social distancing must be guided by public health principles and social and economic considerations. And of course, public-private partnership is the key of the response for the COVID-19. So as I mentioned, to have extensive testing, we had collaboration. Government had collaboration with pharmaceutical companies to produce kits. And the innovative sampling method was actually proposed by some doctors, and those were adopted by the government. And obviously, the collaboration with private hospitals was also a key part. And we also adopted community treatment centers for treating mild cases. So the severe and critical patient could be treated at hospital properly. And of course, many volunteers to Daegu, which was the epicenter, all tried to help. And collaboration with mobile and card companies for tracing, and also developing various apps which was used the response process. And finally, of course, the public participation on a voluntary basis for social distancing was important part. So as a conclusion of public health response to COVID-19 in Korea, the actions taken based on lessons learned after MERS outbreak was important in terms of governance. The Korea CDC established Emergency Operations Center and also Laboratory Analysis Center, and regulatory framework for the emergency use licensing, and also infrastructure and risk communication. So what would be the best practice so far? So I think we can say government handled the situation with no lockdown and only minimum travel restrictions in a democratic and transparent manner. And this was possible, as I mentioned, because of testing capacity from very early stage, and also close collaboration between public and private sectors, and between central and local government. So what could be the lessons learned from this COVID-19? So firstly, I think peacetime preparation would be important. So there was actually the simulation exercise in December last year. The title of the exercise was Unknown Pneumonia from China, coincidentally. And the Korea cities was quite surprised to see real situation after a few weeks. And of course, secondly, securing infrastructure in preparation for such. So this was done after MERS outbreak, but I still think that we still have to secure more for the possible surge of very large scale. And clearly, the governance and control tower issue that I think this time it was quite efficient. And also the close collaboration with WHO and global health initiatives such as WHO Korea Joint Mission on MERS when we had outbreak in 2015, and also in 2017 WHO International Health Regulation Joint External Evaluation. Those were helpful for us to prepare for the next pandemic like this. So I just want to show one slide for the research and development. So government established National Task Force for COVID-19 R&D in 3 areas. So jointly by Ministry of Health and Welfare and Science and ICT, and of course academia and pharmaceutical companies. So those 3 areas will be vaccines and therapeutics and medical equipment. So for the vaccine, among 10 vaccine candidates which are being developed in Korea, 3 most advanced candidates will be supported. So 1 spike protein-based vaccine and 2 DNA vaccines. For therapeutics, like other countries, drug repositioning will be supported, and of course also patient sera and monoclonal antibody to virus. Those 3 areas will be supported for the therapeutics. In terms of medical equipment, PPE, ventilators, ECMO, and some diagnostic equipment, and mobile CT and AI-based radiology will be supported. So what would be the preparation for the next step? Because of the recent increase of the new cases in Seoul and metropolitan area, and also proportion of the cases with unknown source is increasing, so quite difficult to predict the situation in Seoul and Gyeonggi province. But we will have to adjust social distancing to balance public health and economic and societal impact. So that should be done. And obviously, the medical resources for preparing for the next waves will be critical. So that will include facilities, including private hospitals, equipment, and healthcare workers. To do that, we need to further shape a public and private partnership. And one thing I really want to mention is I think we have a lot of data, scientific data, but I think we need to really analyze properly in a very comprehensive way and publish those data and share with the global community. And I do understand there is a serious survey planned for 8,000 people. That is still ongoing, I think. So I hope that that those data will be available soon. And of course, we also need to participate in the international solitary trials for vaccines and therapeutics. And in terms of R&D, I think Korea has quite high proportion of R&D among national budget. But for the infectious diseases R&D, I think we still have to scale up, and also have to have strong partnership with global health partners. And lastly, I want to mention about the WHO's role in monitoring and evaluation of IH trial implementation. So our President Moon made some statement during the World Health Assembly this year, actually last month, about the strengthening WHO's role for the IHL implementation. So I hope that Korea could do some role in this process. I think that's it. Thank you.
Thank you very much, Dr. Ji. And now I'd like to go on to Professor Stern. Professor Stern?
Yes. Hi. I'm very happy to be here, and I have also a presentation that I would like to share with you guys, and I hope it's going to come up and be ready pretty soon. All right, so my presentation is a little bit different. It doesn't focus so much on particular issues, but let me start by saying that there was no lockdown in Sweden. So in that sense, we're very similar to Korea. I think that it's important to understand why Sweden took this unusual step. It's among the European Union members, the only country that didn't practice a hard lockdown. There are many more factors, of course, but two that are, I think, particularly important to understand the Swedish policy. One has to do with culture, and the other one has to do with the constitution. Sweden is a high trust country. We have a high degree of interpersonal trust. That means people trust one another, and we have trust in authorities. And perhaps more importantly, in the case of COVID-19, is that the authorities trust people back. But overall, that means that government or public policy recommendations and informational campaigns are really taken to heart. People practice what the authorities preach, so to say. The other important thing to remember here is that in Sweden, the lockdown, a hard lockdown, a legal lockdown, would be unconstitutional. There is a strong constitutional setting where personal movement and freedom of personal movement during peacetime is a constitutional right. So locking down would be unconstitutional. Another important constitutional law is that there's an independence of public agencies. And we see this importantly when there's in Sweden very much the experts of the Public Health Agency who are setting the tone for our policies. And the Public Health Agency has a mission to promote overall public health. So they start off judging the coronavirus, and now I'm of course mind reading a little bit because I don't really know the discussions going on in the Public Health Agency, but I think that it's clear that the assumptions they had was that this virus is not possible to suppress. We can't just lock down and it will, die out. They also assumed that it wasn't extremely deadly. I mean, the data from Wuhan sort of suggested that what was mostly needed was to protect old people and otherwise risk group people. I think that in the discussion that has followed on the Swedish policy, there has sort of been a portrayal of what I think is a false dichotomy, basically that you have to choose between health or the economy. I am not at all sure that a strong lockdown doesn't have significant public health effects. As a sociologist, I'm aware of research saying when schools close down, a lot of students suffer. When unemployment and economic distress spreads in a society, public health goes down. So isolation, all these other public health concerns, I believe, was also taken into account when the Public Health Agency decided on what could be seen as a soft lockdown. I think that they made the conclusion that a hard lockdown is not feasible in a long enough term. We see here, and we talk about vaccines being developed, and perhaps it will be available by the end of next year. Who knows? There's a significant amount of uncertainty here, and I think that when you talk about the long term being uncertain, you need to have a policy that is viable in the long term. But that didn't necessarily mean that the Swedish behavior didn't practice the social distancing and took to heart the advice given in this sort of soft lockdown policy. What we see here is a comparison over Finland, Sweden, Denmark, and Norway, basically showing the shift in behavior from a baseline behavior after the coronavirus started spreading in the countries. And you see that although Sweden, which is signified by the yellow line, is higher than the neighboring countries, we see that the impact on behavior was significant across the board. Whether we look at travel, whether we look at workplace and other factors, we see that people responded to the outbreak and changed their behavior. So if we are going to talk about whether or not the Swedish policy was a success or a failure, we can see that there's some successes. We were able to flatten the curve, and most significantly perhaps the fear that the ICU would be overwhelmed and that people would not be treated properly did not happen. We also see that we do not need to open up the economy now, although the economic effects of even our soft lockdown is immense. And of course, we can talk more about that later, perhaps. We see that if we think that the Public Health Agency thought that we would reach herd immunity in Stockholm or in Sweden, that does not seem very likely to happen. And we do have had a high death toll, especially among people in elderly care. 88% of the deaths have been among 70 plus citizens, and 70% of those have been in elderly care. So, however, I think we still are at an uncertain stage here. The long-term results of the hard lockdown versus the soft lockdowns remains to be seen. It's still unknown. It's still very uncertain, I would say. And then I just want to reflect a little bit about other reasons not to lock down in a pandemic. I think sometimes people forget that lockdowns are a significant threat to individual liberty or democracy, and what we see in the sort of event of the pandemic is that civilized countries are putting people in house arrest, which is not a good thing, I think. We also see other health costs incurred by the lockdowns, postponed treatments, miserable living conditions. These are effects that should also count towards the sort of balancing of the scales and evaluating the different policies, not to mention the economic costs in terms of unemployment and financial distress. So to me, having been studying this as sort of a social scientist, kind of evaluating and reading and thinking about this, we see that the soft lockdown that we've had in Sweden and in Korea does not seem to be the primary cause of a high death rate. What we see in the elderly homes are mostly the nosocomial spread of disease. What I've also come to appreciate is sort of the guerrilla warfare, track, test, and treat local outbreaks. This is how this pandemic needs to be fought, and I think Korea perhaps has understood that from the get-go. I think that in the Swedish case, we see that we need to strengthen and empower local authorities so that they really take charge and take responsibility when it comes to doing their own making their own actions. And finally, I just want to say something that I think sometimes is also important to underscore, and that is when governments treat citizens as adults and say behave, respond, they respond. And because it's in their own interest, because it's their own health, and they're interested in helping promote the health of others. And hence, I think these kinds of harsh lessons is actually very, very damaging in the long term. And I'm going to quit there, and I thank you for your attention.
Thank you, Professor Stern, for that very interesting discussion of the approach that Sweden took. If we could, perhaps we can have a bit of a discussion, and then we also have some questions from the audience that we can address in the last few minutes. Do you have any questions either for me or for Dr. G, Professor Stern?
No, but let me just comment a little bit. I notice when I'm listening to Professor Yi, just the difference that experience have. You can tell from the way that Korea was on the ball immediately and had a tactic and have planning and everything under control. At least that's what it sounds like to a Swede. You were ready to meet this pandemic, and I think that for Sweden, it was a real shock. And you know, some discussions have talked about Sweden being damaged by long-term peace and not thinking that anything bad can happen to them. And when I listen to Professor Yi, I kind of feel like, yeah, we did not sort of see this coming. And so I'm very impressed with sort of the preparedness of of your country.
Dr. G, do you have a comment?
Well, I don't know whether you can actually answer this question, but from the data which I found from the list of the countries for the death and recovery rate, I realized the recovery rate in Sweden is relatively low. So I wonder why. So for many other countries, recovery rate could be much higher, but I noted from Sweden it was like less than 10%. So for us, it's about 90%. For some other European countries, it can be higher, much higher than Sweden. So, so you mentioned that the ICU is not really overwhelmed, so it's working properly, and it's my curiosity for the relatively low recovery rate among your patients. Maybe.
Yeah. So that's. I'd like to remind you that I'm a sociologist. And if I should guess, I mean, it might be that a lot of the people who die, I don't really know. How maybe there's a difference in how we count recovery rates. Is that possible? Since we don't track people so well that have had COVID unless they've been tested and treated, in the hospital or by a doctor, perhaps we don't really know how many of sort of mild symptoms COVID-19s that we have had.
I note actually some mild cases were just treated at home. So in Korea, those mild cases are still treated in community treatment centers. But in Sweden, I think, because I know one of your, one of the SAGE members, WSAGE members, she was actually, she got infected and she was staying home, I think. So she just home treatment. Because she was a doctor, she just self-described, prescribed the
Self-medicate,
yeah, self-medicated. So maybe that is true, but anyway, that was my curiosity.
Yeah, I don't really know. I'm just speculating, of course, at this point. But I know that we are sort of slow in tracking and testing for antibodies and stuff like that. So maybe over time we will have a higher recovery rate.
So the other thing is, what would be the people's perception on your strategy for responding to this COVID-19 among general population?
There's of course wild debates going on also within Sweden among both professionals and the general public. But overall, I would say that the support for the Swedish policy is high. People are not questioning the wiseness of the Public Health Agency. I mean, that might change, of course. We don't really know. These things kind of evolve. But I can tell you that it is not as high as it is in Finland, Norway, or Denmark. So the hard lockdowns of our neighboring countries are more popular in their citizenry than our soft approach is in our citizenry. So.
Thank you. And maybe if you could use the National Serial Survey as a basis for estimating the total number of people who have been exposed, and then that might give you a better estimate of the number of people who've recovered.
Indeed.
Did you have any questions, Dr. Lee, or comments?
Yes, indeed. I had one question. You said lockdown is unconstitutional in your country. Do you think contact tracing is also going to be unconstitutional in your country? Would it be possible to adopt contact tracing system?
I am not sure. Extreme situations sometimes require extreme measures. I think that the type of forcing people to respond to an app like you have in Korea would not perhaps be seen so. It would not be popular in Sweden, I think, because of integrity reasons. That doesn't mean that people could not be persuaded to accept it because of this extremeness of the situation, but I'm just saying that just culturally, I think that people would see that as an infringement of just their privacy. But everything's relative, and things might change.
Professor Stern, there was a question from one of the audience members for you. Could you talk a bit more about the soft lockdown? What exactly is a soft lockdown?
Well, I was hesitant how to name it. First, I was thinking that a voluntary lockdown, perhaps. But what I really mean is that just as I understand Korea's approach, saying that people should practice social distancing, they should wash their hands, they should stay home if they can. This has very much been the case in Sweden. People have been recommended to work from home if possible. People have been recommended to wash their hands incessantly as soon as they come in and out of, just having been in contact with other people. And we see that this has had an effect. The normal flu has just disappeared. And but still we have some legal restrictions. It's not allowed to gather more than 50 people in one place. So major public events have been canceled, and so forth. But what I really mean is that the government has not said, you have to close everything down. So the stores have been open, restaurants have been open, but with less people and very visible signs to keep distance everywhere.
All right. Thank you. Did you have any questions for any of the, or comments on, again, for any of the other panelists?
I guess I'm a bit curious about the app that you have development in using the ICT. How much do people follow the rules?
Do you mean the mobile app for the quarantine? So everyone actually have to download that app, and that has been very massively used. Actually, my daughter actually was also using that for 14 days until just a few days ago, right after arriving from Berkeley in US.
My daughter also.
Yeah, so it's same situation. So everybody need to actually follow that procedure. So, but in case they leave the phone at home and go out, that's going to be a problem. And also if that happens, once the public health officers check and there's no answer, then they will actually visit and check if they what happened. So some people were caught actually. So that's going to be a problem. So that in such case, I think there will be some some fine. So everyone need to follow that rule. So that has been very strictly adopted, I think.
I have one comment on the Korea's contact tracing system. It seems like there is some misunderstanding about contact tracing in Korea. If you imagine a time when there is an actual war, it's like giving a warning signal to the people by the government where the bombing is going to happen. So it's not, all area, tracing all the people, all the time. It's like giving a warning signal to people living in a certain area that there is going to be a bombing. So people can very naturally adapt to this kind of system in Korea.
I think somehow that's the prerequisite for the no lockdown situation. Otherwise, we need to really apply very strict lockdown. With that, we were able to have just voluntary basis. Otherwise, it's difficult to control really. So that's I think a balance.
And I think also there's increasing information that wearing masks may actually be an important form of protection, which wasn't necessarily the case before this outbreak. And I mean, I think it just gets to the idea that everyone potentially is infected, and when you're wearing a mask, especially the asymptomatics, you are protecting people. I don't know what the level of mask usage is in Sweden.
It's very low. As a matter of fact, I think perhaps 10% of people wear masks in Sweden. And there's been a very strange discussion concerning this, where I think that it's been too much of a focus on the mask protecting you. And I think that the whole notion that you actually protect others by wearing a mask is a very much more important message to send. I suspect that partly this has been due to a shortage, perhaps, of just equipment, and that the public health agency has been afraid that people would, deplete the hospital needs by buying up face masks. But that's just my. I don't have any proof of this hypothesis at all. I just suspect that somehow the hesitation to recommend face masks has something to do with a shortage somewhere down the line.
So there was no official recommendations for wearing a mask from the government? No.
No. Only if you work with people. I mean, in
Healthcare
healthcare or
workers,
in
yeah.
elderly care. Yeah.
Right. And so we actually have two more questions. I think I'll take the first one. I'll take the first crack at the first one. Given the intensity of the current pandemic global crisis, why are human challenge trials on volunteers so readily dismissed on ethical grounds in the media? And actually, this is a very important question and gets to the ethics behind human challenge trials, as we call them. I was trained at an institution that did human challenge trials for dengue and malaria and enteric and diarrheal disease. And it's very important. It moves the field forward in very important ways. One of the things that we're hoping is that if there were challenge trials for COVID-19, that it might accelerate vaccine development. I think, though, that one of the other things that maybe we didn't realize at first was how quickly vaccine development would proceed in COVID-19. So that in the time that it would take to set up human challenge models, we might actually have proof of concept that the vaccine actually protects and is safe in standard phase 3 human clinical trials. Even then, human challenge trials could be important because they could accelerate the search for things we call correlates of protection. That lab test that will tell us why a vaccine is working, that we can use then to accelerate future vaccine trials. That rather than having to do a trial in 30,000 people, we might be able to do a trial in 1,000 people and really much more rapidly develop improvements on the vaccines that are shown to exist. The other reason that human trials could be important would be for development of therapeutics. And there are lots of different reasons to understanding how the disease progresses in the human body. These are things that we can do with much greater precision and with much greater scientific interest if we can control the infection or the time of introduction of the infection. That being said, there are a number of very important ethical questions. Does a person understand that they, in acquiring this infection, could die or could get very sick, might have to be on a ventilator? Now, we would think that a younger person, say someone under 30, has a very low risk of death, but a significant number of people are put into the hospital, and there are sometimes unknown consequences. And I reference one of the challenge trials that we did before fully understanding that certain types of malaria might be persistent despite the use of kinds of medication. We know the reason for it now, but people might have unfortunately been exposed to risk. Now, these are risks that volunteers would normally accept. Not all countries around the world accept human challenge trials ethically. So that's one issue, that a country has to be willing to say that a challenge trial is ethical. There's going to be some time in development, so that we'll have to develop the testing model, and that will take on the order of months. So again, I think that there are still many people who talk about this, that there is still interest in it. But challenge models are going to be something that I think many people are saying that the timing is not right now, or that the ethical issues have to be worked out. But we were thinking about challenges for Zika, which is again a disease for which there is no known treatment. So I think these are things that we have to bring out into the open, that ethicists and scientists and clinicians and volunteers should talk about. There are 10,000 people who've currently volunteered for future challenge trials. I think that number may change once we explain the risks and the potential benefits of the challenge model. But I think there is still a lot of interest, but it's still something that's being developed. Yes?
Yeah, so in addition, if I may add, actually I heard some debate on the use, because the first trial will be for the young people, young population, and real need for the vaccine might be the older population and some people with underlying disease. So we with the outcome of that first trial, maybe that same results cannot be applied to real people who really need vaccine. So that's the one thing. And also, as you know, the vaccine-induced disease, it could be some enhancement. So that really should be rigorously tested in animal models first. So, yeah.
Yeah, and so I think that that's a very good point. And one of the reasons that vaccine trials are, challenge trials are being brought up is exactly that there are over 150 candidates, and that the vaccine trials, challenge trials may allow us to down select the candidates that are the most interesting and not have to test those that don't develop protection against challenge. But you're absolutely right about finding the target population. But those target populations may also be delayed in terms of testing because immune responses are not optimal in elderly individuals. So there are lots of important questions. Dr. Stern, did you have a...
Yeah, I can, if I can chime in on that, I think that, again, I mean, in some sense, if it makes sense scientifically, I think that adults should be able to decide over their own willingness to participate. So just as a principle, I think that these kinds of decisions could be reasonable and just be acceptable more. That's my take.
No, I think that the principle of autonomy is one that ethics and institutional review boards consider very highly in this. The last question, I think, is one, and perhaps Dr. G can answer this. Making vaccine would require enormous amounts of money. Will it really be possible for people who are not protected by insurance or national medical systems to receive the vaccine? For instance, foreigners, refugees, I would guess people in less developed countries.
In less developed countries, I think there was a vaccine summit with many global leaders participated last week, discussed the fundraising for those people in middle and low middle income countries. So that I think that there is quite high participation among different countries. So that's the one approach, I think. So we will have to really make sure that kind of separate fundraising for those countries so that people also can have access in those countries.
Right, and I think, so Gavi, the Vaccine Alliance provides vaccines specifically to countries that are unable to afford it at either greatly subsidized or no cost. So that will be an important part of the global response. And then I think within countries, what we've begun to realize about COVID-19 is that, for instance, in Singapore or in other countries, there are populations of migrant workers and others who actually are a potential source of infection in the community. So that as a country is developing its own policy around use of COVID-19 vaccines, they really need to consider the sources of infection within the population. And that will undoubtedly include considering vaccinating everyone within a country as a part of national policy. And then, the cost of that vaccine, again, we don't have a good estimate yet because there are so many different candidates out there, it's really difficult to come up with an accurate cost of goods. But I think that the companies that have accepted funding from CEPI, many of the companies that have accepted funding from national governments are committing to reasonable cost vaccines.
So I don't know about Sweden, but for Korea, our target is like producing 5 million doses by the end of next year. So 500 is only 1/10 of whole population in Korea. So we will have to prioritize which population will be vaccinated. Obviously, like healthcare workers and older population, some people with underlying diseases. So the key would be the really scale up the production. So that's the challenge for every country, I think.
No, I think that's right. Yeah.
Okay. All right. So we'd like to thank everyone for watching this webinar sponsored by the Korea Foundation and providing insight into the similarities and some of the differences between the approach to COVID-19 pandemic in Sweden and in Korea. And then also for the opportunity to present some information on vaccine development for COVID. Hopefully that's answered some questions and maybe generated others that we really do need to address productively in the future. Any final comments?
No, I would like just thank you, Dr. Stan from Sweden, and thank you, Dr. Jerome Kim, for beautifully moderating the session, and thank you very much, Dr. Ji, for joining us together.
Thank you,
Thank you
Dr.
for
Lee.
having me.